Hello. For any of those watching who don't know me, my name is Dr. Lowell Chambers. I'm a general surgeon with emphasis on trauma, surgical critical care, and hepatobiliary pancreatic surgery in my practice. In regards to the ventilator support of our surgical and trauma patients, I've become increasingly convinced that our current standard management with low tidal volume principles as endorsed by ARDSNet is an inadequate standard for most of our patients, and that a better way forward is an alternative vent mode, airway pressure release ventilation, APRV, and specifically the time-controlled adaptive ventilation mode of APRV or approach to APRV, TCAV. We've broken our discussion on this down into three basic parts. In the first discussion, we focused on why I believe that TCAV is the best vent option for most, at least, of our trauma and surgical patients. In this second podcast, which we're going to focus on over the next hour or so, we want to look at how to effectively use TCAV. And then in a future lecture, we hope to look at case studies and some examples of avoidance of pitfalls and some examples of the good outcomes which I think can be achieved in utilization of TCAV APRV with some of our critically ill patients. Okay, so as we go forward in this second of our three-part series to help introduce each of us to TCAV, we will be looking at how TCAV APRV is set, adjusted, and weaned, and we'll try to illustrate some of the potential pitfalls and how to avoid them. But by means of review, and if you haven't watched the first lecture, I would encourage you to do so. But in brief summation of our prior lecture, why go to the hassle of learning a new vent mode? Why TCAV APRV? Well, we saw that hypothetical advantages and conceptual advantages supported in the literature include the ability for TCAV APRV to permit for spontaneous breathing despite giving significant both ventilatory and oxygenation support and significant reversal of I to E, but without the need for neuromuscular relaxation and significant sedation. Decreased ventilator-induced lung injury, which occurs as a result of that and other components of APRV. Improved hemodynamics, as well as maintenance of diaphragm and muscle tone. And at least in trauma patients, this has been demonstrated to lead to improved outcomes with ARDS and perhaps more compellingly, a decreased incidence of the occurrence of ARDS. Now, I want again to emphasize, none of this is my work. I'm simply trying to incorporate the TCAV methodology, which the team at Baltimore Shock Trauma and elsewhere, but primarily Dr. Abashi and his team at Baltimore Shock Trauma have worked out over the last 20 years or so. And frankly, the vast majority of what I'm sharing is available on their website, tcavnetwork.org, which I've pictured here. It's all free. They've not developed it as much as I had hoped for them to. It seems like they've kind of plateaued on that, but nonetheless, this is a great resource on how to get started on TCAV and how to adjust TCAV. It's really, I think, the best information you're going to find on this, what I think is a revolutionary vent mode. So I strongly urge you to get on tcavnetwork.org. All you got to do is sign up for an account. There's no cost involved. It's non-proprietary, and you have access to all of their information and the experience which they share on there. And Dr. Abashi and his team, some of which are pictured here, Mr. Neiman, who's a researcher, Penny Andrews, who's a nurse, Maria Madden, one of their senior respiratory therapists. They've done a tremendous job in advancing both treatment and avoidance of ARDS with the TCAV modification or the TCAV methodology of APRV. And this is primarily on trauma patients, but I think we're going to see increasing applicability to many other surgical and medical patients as well, which we'll get to primarily in the third lecture. Well, despite being around since the late 1980s and despite a number of potential advantages which have been long recognized, airway pressure release ventilation has never been a widely adapted and a widely accepted and a widely utilized mode of ventilation. And despite these advantages here, it's just not caught on. And I think the primary reason, frankly, is it's just different. And different approaches tend to make us nervous, especially with complex and critical tasks such as ventilator support of critically ill patients. Whether it be ACVC, ACPC, or ACPRVC, or SIMV, most traditional positive pressure ventilators in use since the 1970s require knowledge of how to set and adjust the core parameters of FiO2, rate, tidal volume, PEEP, and, in some more advanced circumstances, I to E ratio, or if you're doing pressure control ventilation, then pressure in place of tidal volume. But these are the basic standards that, we've, over however many years of practice we've been in, we've become very comfortable with setting initially and then adjusting in response to hypoxia, hypercapnia, and other issues. Well, with APRV, you set the FiO2, but there's no rate that's set. There's no tidal volume that's set. There's no PEEP that's, well, we'll talk about PEEP. It's set differently. And you don't set an I to E. You don't really set any of these in the traditional fashion. The rate, the volume, the I to E ratio are all determined secondarily through adjustments to parameters of T high, P high, T low, and P low. And it's very foreign and uncomfortable, particularly the first few times. And the natural tendency, if things don't go perfect, is to fall back on what we're comfortable with and abandon the mode and blame any problems that the patient's had on the new mode, which, number one, if we're inexperienced and unless we've been well trained on that particular mode, it may be more our fault of misusing the instrument, blaming it on blaming the problem with hammering on the hammer when it's actually the one who wields the hammer, or the scalpel, or in this instance, the ventilator mode, or maybe that ill patients or sometimes have problems, but it's easy to blame the new modality on that. So it makes us uncomfortable. But I'll remind you, as we elaborated on during the first lecture, what we're comfortable with isn't getting the job done right now. We're stuck with a 30 to 50% mortality rate with ARDS, which has not really improved significantly over the last 30 years. So I think the main reason APRV hasn't been embraced is primarily it's different. Compounding that is there's been a significant amount of confusion created by multiple different names for the mode, some of which are proprietary. And if you've got a Puritan Bennett, it's going to be called bi-level, whereas if you're on a GE or a Draeger component, it's going to be called APRV. And so there's all these different names, and it becomes very confusing. And then in some instances, there's actually little idiosyncrasies between, for example, bi-level and APRV, which we'll touch upon a little bit at the end. And this has only increased confusion and angst with the change with the ability or in the course of trying to change to a new vent mode. There's also been a number of different ways that APRV has been utilized, and you'll find in the literature under the nomenclature of airway pressure release ventilation wide ranges of pressures and release timing and personalized versus fixed ways to do APRV, whether depending upon settings are or are not adjusted in relation to lung mechanics. And so each of these waveforms, which you see here, which are these pressure waveforms, which are quite different, all have fallen at different times under the nomenclature of APRV. And so when I say that I think we need to transition to airway pressure release ventilation as the primary vent mode on our trauma service, I'm specifically referring to TCAV, time controlled adaptive ventilation, APRV, as described and popularized by the Baltimore Shock Trauma Group. The core constituents and the core characteristics of TCAV are a long inspiratory time, typically greater than 90% of the cycle, at least once the patient has become stabilized, at a relatively high pressure, typically at least in the 20s and sometimes in the 30s and on occasion on rescue cases even in the 40s initially. So long inspiratory times at relatively high CPAP pressures punctuated by very rapid releases. APRV is essentially CPAP plus releases. And in TCAV, specifically time rather than pressure parameters are utilized to favorably influence pulmonary mechanics. So there's a lot of different things in the literature called APRV. I'm not talking about a lot of different things here. I'm talking specifically about the principles of time-controlled adaptive ventilation as laid out initially and as has been evolved by Dr. Hibashi and his group over the last 20 years at Baltimore Shock Trauma. Okay, so having said that, let's move past generalities and concepts to physically kind of hands-on with the vent. How do we do TCAV? How do we make this work on the vent? How do we set the vent and how do we adjust it to changes and problems to address hypoxia, hypercapnia, hypotension, other issues which may develop? There's 4 basic parameters to set with APRV. 2 pressures, P high and P low, and 2 times, a T high and a T low. And so how does all this work though? It kind of maybe looks like this looking in, but it's actually conceptually not that difficult. Briefly, P high and T high determine the CPAP phase, if you will, the airway pressure of airway pressure release ventilation. P high is the level of CPAP here, which is held for the majority of each cycle. T high is the length of time that the P high is held prior to allowing a very brief release. To start with, when patients are initiated on TCAV APRV, particularly if it's a rescue type of situation or an unstable patient, you're going to tend to start with high P highs and shorter T highs. And then gradually, as the lungs recruited, you can utilize, as Dr. Hibashi calls it, dropping and stretching, where the P high is gradually dropped while the T high is increased, and the patient is ultimately weaned toward pure CPAP in that fashion, because APRV, again, is CPAP plus releases. If you take APRV minus releases, that equals CPAP, and then you're ready to essentially extubate the patient soon thereafter. P low, the low pressure setting, and T low, meanwhile, determine the release ventilation of airway pressure release ventilation. With TCAV, as endorsed by the Baltimore Shock Trauma Group, P low is always 0. Now, with our GE vents, with our current vents, our GE 860s, it may just be I'm not doing something right, but I've had problems with that where I have to end up setting it typically to 1. But you set the P low very low, and again, at least on the Dragers as endorsed or as utilized at Baltimore Shock Trauma, they set it to 0. But P low is essentially set to 0, and we'll talk more about that. T low is very short and is typically somewhere in the range of 50 to 75% of peak expiratory flow rate. It's truncated at that point in order to prevent de-recruitment, which occurs if you leave the patient at the low pressure for too long. And the setting of T low, for me, gets a little bit complicated, and we'll spend a fair amount of time on that later in the lecture as a result of that, and try to overcome that. Potentially the most important point to be made regarding initial APRV parameters is I believe that one size does not fit all. And we've got an English bulldog named Charlie, and you can see that here for this bulldog is not doing well trying to come through this small door. The same type of result will occur if you try to take a set certain settings of the parameters of TCAV or of APRV and use those universally. It does not work. One size does not fit all. And that was one of the things I struggled with initially in trying to utilize APRV, and I think others have struggled similarly. This is a weaning sequence published by Dr. Abash in one of his early publications back in 2001. Now, this was meant just as an example of how to wean APRV, but I think a lot of us, myself included, took this as an algorithmic approach to APRV. And so, if I was trying to put somebody on APRV, regardless of what the extent of respiratory acidosis they had was, regardless of what their current respiratory rate was, how stiff their lungs were, etc. I tried to make this a one-size-fits-all, where you're putting everybody on a T high of 4 initially and a T low of 0.8, and this just does not work. This was meant as an example, not as an algorithm. TCAV APRV settings have to be tailored to the patient and to the situation. So you can't use a one-size-fits-all as some of us have attempted to in the past. And trying to rescue a hypoxic patient in extreme ARDS who is both hypoxic and acidotic is quite different from a stable patient who just needs an interval of vent support after, let's say, a pancreatic duodenectomy. Ventilating, for example, an elderly COPD patient on home oxygen with pneumonia in similar fashion is different from ventilating an otherwise healthy young person who has significant pulmonary contusions or fat embolism syndrome. So one size does not fit all with APRV. And I've modified this, but primarily this is data and guidance from the TCAV network site. It depends what your initial settings should be, depends upon the situation that you're in. And if you can just look here, generalities are the sicker the patient, the harder the patient is to ventilate, likely the higher P highs you're going to need initially, the shorter the T highs that they're going to tolerate, and typically the stiffer the lungs are going to be, because ARDS is what we're talking about in most of these instances. And ARDS patients get stiff lungs. Stiff lungs, they snap shut quicker. So your peak expiratory flows are quicker. So your T low has to be quicker. Otherwise, you get de-recruitment. And so just generally speaking, the sicker the patient, the higher the P highs, the lower the T highs, and the lower the T lows. But here are some specific ranges and guidelines, which I think will guide you well. But there's no substitute for just once you get a patient either transition from another either volume control mode or pressure support mode, or a patient who's newly intubated, there's no substitute for staying at the bedside and seeing how they respond to those initial parameters. And I'll try to emphasize that again and again, because I think that it is something that can't be emphasized too much, is see how the patient reacts to what settings you have them on. And sometimes even small tweaks of particularly T low can make a big difference. But if you're not at the bedside to see it, then you can't make it. You can't make those changes in as informed a fashion as you really need to. Now, again, one size does not fit all. So I submit the chart to you as the most helpful thing here. But just all other things being equal, if a patient's not particularly unstable, I typically tend to be a little bit on the conservative side, starting with relatively high P highs, usually around the 28 range. Again, at least on the GE vents that we're currently using, I just set the P low to 1. Baltimore shock trauma, they set it to 0 specifically. We'll talk more about that. T high, I go pretty low at first at 2 seconds to make sure there's enough bulk ventilation as the patient transitions over or as the patient's newly intubated. And T low, usually initially set it at 0.4, and then we see where we're at in relation to the expiratory flow termination as compared to the expiratory flow peak and ratio, and we'll talk specifically about that, and also how you can just see what the release tidal volumes look like and base your adjustments and your tweaking, if you will, your initial tweaking based off of that. Transitioning from a volume or pressure control setting, it usually works to set the P high around the peak inspiratory pressure or the plateau pressure, and the T high such that an appropriate respiratory rate is maintained. Because although respiratory rate is not a set parameter on APRV, it is indirectly set through the T high and the T low, with the combined time of T high plus T low equaling 1 cycle in seconds, so that with 60 seconds per minute, you take 60 divided by the combination of T high and T low, gives you the number of cycles and releases, which is essentially akin to your respiratory rate. For example, if a patient is breathing 30 times a minute on AC/VC and the pH is okay, and if the T low is, let's say, 0.4, and we'll talk about how you set T low more shortly, but for now, say the T low is 0.4, then an appropriate initial T high would be 1.6, as is diagrammed out here. If you try to start, let's say, with a T high of 4, that's going to produce a respiratory rate of 14, which will likely lead to respiratory acidosis in a patient previously requiring a rate of 30 breaths per minute. Now, with any patient that one is either just intubated or with whom a major vent change has been made, again, it behooves us to stick around at the bedside for a while and see how the patient does. And this is particularly true with APRV. If they become tachycardic, if their tidal volumes are very low, if they have irregular expiratory waveforms, if they look more agitated, then adjustments probably need to be made acutely, maybe even before you get an ABG. And sometimes just subtle changes in T low or T high in some instances, or changes in P high can make a big difference. And just standing at the bedside and performing some initial tweaking, if you will, of the vent is oftentimes a very helpful thing. One also has to be on the guard for hypotension, particularly if a patient is hypovolemic. Hypovolemic patients don't do real well with APRV. They don't tolerate it well. So if there's a chance of hypovolemia, it's recommended that you take some means to address that prior to switching over to APRV, or as much as is feasible prior to intubating the patient. And that's not always possible if the patient is acutely decompensating from a respiratory standpoint, but certainly with some of our hemorrhagic trauma patients or some of our septic patients, you sometimes have a little window where you can aggressively volume resuscitate that patient prior to intubation. And particularly if you're going to be utilizing APRV from the get-go, that's a good idea. If the patient needs blood, if they're a bleeding trauma patient, then certainly that's the best fluid, that's the best colloid to use. Otherwise, I like using albumin in this setting, particularly if the patient is hypoalbuminemic, but even if they're not, they tend to hold on to it a little bit better. So a crystalloid bolus is reasonable, but I'll often use a 5% albumin bolus, 250 or 500, prior to APRV initiation in the setting of possible hypovolemia. Now, if the patient's euvolemic, or certainly if they're volume overloaded, as many of the patients that we're dealing with ARDS and are, then that's not necessary. But the point is that hypovolemic patients do not do well with APRV, TCAV, or otherwise. Additionally, while APRV typically enhances left heart function, it does increase the preload that the right heart pumps against. So it can worsen right heart failure. And APRV is not a good vent mode for patients with pulmonary hypertension or other causes of right heart failure. And that can lead to hemodynamic consequences if it's unrecognized prior to switching the patient over to APRV. Another pitfall with APRV, particularly in patients with fairly normal lung compliance, is hyperinflation. APRV works through auto-P, but if you generate too much auto-P, the patient can become hyperinflated. Evidence of this is hypotension, a widened or squared off expiratory waveform that you see here. Here's what you typically want to see with properly set APRV on the expiratory waveform. And as patients become hyperinflated and becomes harder for them to release, this becomes squared off, becomes elongated or stretched out, if you will. And so you'll see these squared waveforms in the setting of hypotension, and the patient just showing distress as they try to exhale. The action, if you see this, is to initially, like with the hypotension due to hypovolemias, drop the P high if the oxygenation can't at all tolerate it. And then get a stat chest x-ray, because this could also be seen with tension pneumothorax. And so think tension pneumothorax, also secondarily think hyperinflation. Drop the P high. If you have any question about their volume stats, maybe give a fluid bolus and get a chest x-ray. And obviously the chest x-ray will show you pneumothorax, which this kind of looks a little bit like here, but this is actually just a pacing pad in this picture. But if you don't see a pneumothorax, but you do see abnormally cleared lung fields, then what you're likely dealing with is acute hyperinflation. So with this, you see the difference between the two chest x-rays here. Here's prior to APRV, here's after APRV. You see that the diaphragms have flattened out here. The mediastinal silhouette has become narrowed significantly, and you've got atypically rapid clearing of the peripheral airways here. So chest x-ray consistent with hyperinflation, again, flattened diaphragms, narrowed mediastinum, rapid peripheral lung clearance. And in that instance, you need to drop your P high a bit more rapidly than you typically would. Typically drop it down by about 3, particularly if the patient is hypotensive. In other instances, you may also need to increase the TL to give a little bit more release time. Okay, so having touched upon some general observations about initially placing a patient on APRV and some of the pitfalls to look for, let's look at each of the APRV parameters more in depth and individually in depth. P high. P high is the CPAP pressure setting. Again, in most instances, typically start in the higher 20s. In extreme rescue cases, I've gone as high as 45. If you're transitioning from volume control, I typically still use the peak inspiratory pressure, although the formal recommendation from the shock trauma group is to use the plateau pressure. And transitioning from a pressure control, then pretty much everybody agrees you would set your initial P high at or around the peak inspiratory pressure. With the exception of hypotension, most acute problems, whether they be hypoxic or hypercapnic, can benefit from higher P high levels. So if things don't go well initially, unless you're dealing with hypotension or evidence of hyperinflation, then likely you can, or one of the things to think about doing to address the intolerance or the issues is to go up on the P high. Going up on the P high tends to pretty reliably help with oxygenation, and it does so without worsening the hypercapnia. Indeed, particularly after it's been set for a little while, a higher P high actually also helps with clearance of CO2. So looking at a basic guide to APRV adjustment, we see that increasing P high is near the top of the list for both improvement of oxygenation and improvement of clearance of carbon dioxide. So P high kind of reminds me of that kids movie I got drugged to years ago with my twins, the Lego movie, where everything is awesome. Everything is awesome with P high. Get you better oxygenation, helps clear your carbon dioxide better. So everything's awesome with P high. And as the pressure has a little more time to apply, everything is kind of awesome because the high pressure of APRV is applied in a more sustained fashion as compared with conventional ventilation. And this results, as Mr. Neiman likes to say, and as Dr. Abbasi likes to say, in the lungs being nudged open and held there, rather than intermittently blasted open by recruitment maneuvers and then being allowed to collapse again. And it appears to be this movement and strain of frequent reopening that induces ventilator-induced lung injury rather than the distension from pressure itself. The more sustained, albeit high pressure, does not appear to cause ventilator-induced lung injury. And thus the high pressures, if applied appropriately, actually facilitates not just direct alveolar opening, but also indirectly via the pores of Kohn, the bronchial alveolar canals of Lambert, and the interbronchial channels of Martin, you get even more alveolar recruitment. And with this enhanced alveolar recruitment, you obviously have beneficial effects on oxygenation, but it also provides a greater number of functional alveoli for ventilation as well. And so you get, as that P high is applied over an interval of time, not just significant improvements in oxygenation, but also better clearance of carbon dioxide. And despite these high pressures, so long as the patient's lungs are not subjected to the high dynamic strain of frequent opening and closing, the lungs are not injured, as demonstrated on these post-necropsy pictures of pig lungs. Both were subjected to injury in this model. Both were ventilated at high plateau pressures of 40, but only the animals subjected to high dynamic strain with frequent and repetitive opening and closing demonstrated injury. So to some degree, with P high levels or with the increased P high levels in TCAV, everything is awesome. But of course, there's no free lunch with medicine. Everything we do can have downsides, and too much of even a good thing becomes bad. And if you go too far, you'll pay the piper. And with too high of a P high, again, you'll get hypotension. You may start to get increased amounts of pneumothoraces and some barotrauma. And again, you're going to be more prone to hyperinflation. Short of these issues, though, it's usually beneficial to start with pretty high P highs, especially in rescue circumstances. Once you get the lungs recruited, then, and you need to wait at least 24 hours, as we're going to talk about, because just because you get the lungs open doesn't mean that they are stabilized as open. And if you decrease that P high too quickly, you'll lose all that recruitment that you got. But once you get the lungs recruited and you've had them recruited for at least 24 hours, then you can slowly, at least initially slowly, start to wean the P high down gradually, usually with concurrent increases in T high, the drop and stretch weaning that we'll talk about. Again, you must keep in mind, though, it takes at least 24 hours for the recruited lung to stabilize. And if you start dropping the P high within several hours, the patient will likely de-recruit and be at risk for recurrent atelectasis and hypoxia. So unless compelled by hypotension or hyperinflation, start with a fairly high P high and stay there for a day prior to slowly starting to drop it. Because dropping it too soon, you'll have these problems. You'll become hypoxic, you may worsen your hypercapnia, and you can, to some degree, offset that, obviously, with stretching out the T high, with increasing the FiO2, but your lung will de-recruit if you do this too soon. The FiO2, meanwhile, can be weaned sooner and should be weaned first. Ideally, by TCAP methodology, you get the FiO2 down to 40% prior to starting to drop and stretch. So don't be in a big hurry. I know everybody gets concerned because we're at these high pressures, but again, it's not the pressure that really matters, so long as you're within reasonable numbers. The problem that gives you ventilator-induced lung injury is the movement. And with TCAP, you don't have that movement. So the pressure, don't worry about it. Get the patient on a good P high, keep them there. Keep them there for at least 24 hours. Get the FiO2 down to 40%, and then and only then start thinking about trying to drop that P high. And as you drop the P high, as we're going to talk about, you have to start to increase the T high to offset that. Prior to moving on, I think it's important to reiterate how ventilation occurs with APRV. Carbon dioxide is offloaded through three mechanisms with APRV. Number one, like with plain CPAP, through spontaneous breaths on top of continuous positive airway pressure. And so something to think about if you're struggling with hypercapnia is to be sure that, unless there's some contraindication otherwise, we're allowing the patients to breathe spontaneously. And other than some instances where you just need to take control of an unstable transition, it otherwise makes no sense to paralyze or deeply sedate patients on APRV. Now, for most patients requiring intubation, obviously the CO2 clearance generated from spontaneous breathing is not sufficient in and of itself, and that's why Downs and Stock had to find a way to provide releases to allow intervals of bulk ventilation where larger boluses of CO2 can be exhaled, and that's where mechanism 2 comes in, which is the primary one when you have someone who is in the midst of significant vent support with APRV occurs, and that's through the releases. These releases can be increased by decreasing the T high, which results in more releases per minute, and or increasing the T low, which increases the length of releases and therefore the amount of bulk ventilation and the bulk amount of CO2 blown off. The third mechanism, a little bit less intuitive, and that is what we just touched upon, decreased alveolar dead space. This again relates to a greater number of alveoli being available with recruitment for CO2 offloading as the lung is recruited, and therefore the dead space is significantly diminished. As the lungs are recruited, this has an increasing effect to the point where ultimately the releases are no longer needed and the patient's ready for CPAP, during which mechanisms 1 and 3 are sufficient for CO2 clearance. So again, spontaneous breaths, releases, and then decreased alveolar dead space. And points to keep in mind as we go forward and as we talk about this more, which may be a benefit in regards to hypercapnia management, avoiding paralysis and oversedation. The one exception is, as patients are sometimes transitioning, you just kind of got to take control of the situation, or certainly when you initially intubate someone, you got to kind of take control of the situation. It may need to transiently, or typically will need to transiently deeply sedate the patient and neuromuscular relax them, but you don't need to keep that going with APRV, unlike most other vent modes when you're ventilating somebody who's in extremis from ARDS. Okay, so hopefully we have a pretty good understanding of how to set P high, as well as a preliminary knowledge of how to adjust for hypoxia, hypercapnia, and hypotension. Let's move on now to talk about P low. And with P low, it's pretty simple, right? As per TCAP protocol, you just always set P low to 0. Well, yes and no. Not all authorities agree on the setting of P low at 0. Indeed, in Zhao's 2017 study, the Western China randomized prospective trial in which APRV showed benefit over low tidal volume ventilation, their protocol actually called for a P low of 5. And the concerns that Dr. Zhao and others who endorse setting a P low above 0 is that dropping the pressure all the way to 0 will result in lost auto-PEEP and de-recruitment, thus offsetting the primary mechanism through which APRV exerts its benefits. The key, as Dr. Habashi emphasizes, is time. With TCAV, time is used more than pressure to favorably affect pulmonary mechanics. And because the T low is kept so short with TCAV, even though P low is set to 0, it never really gets there. The actuality of what happens is not truly like shown on the more squared off pressure wave tracings, but it actually is more like this dotted line, where even though P low is set to 0, it never gets there, not even close. The viscoelastic behavior of the lung, as well as the resistance in the artificial airway, both result in it taking about 1.5 seconds for pressure equilibration to occur. Most T lows in TCAV are between 0.2 and 0.8 seconds, so there's not time to equilibrate to the set P low of 0. So even though P low is set to 0, you're not actually dropping to a P low of 0. The pressure typically only makes it about a third of the way down. And so you don't lose the auto peak because the pressure is never dropping close to 0. And in most instances, the lowest pressure, or the end expiratory lung pressure, or the auto peak pressure, is somewhere between 1/3 and 2/3 of the P high. Now on the Drager vents they use at shock trauma, one can calculate this end expiratory lung pressure, or auto peak, with an expiratory hold maneuver as pictured here. And from that, one can calculate a driving pressure if you wish, because driving pressure is not, and this is an important recognition, is not P high minus P low. Driving pressure on TCAV APRV is P high minus the end expiratory lung pressure, or the auto peak, which again on Dragers can be managed with an expiratory hold. I've tried that on the GI vents that we're currently have in our centers, and I've not been able to get it to work. And maybe I'm just not doing something right. But in any case, the important recognition is that so long as your T low is set appropriately short, you're not dropping to the set P low of 0. You're dropping to an end expiratory lung pressure, or an auto peak, which is typically only dropping about 2/3 of the P high. So in this particular example, you see the expiratory hold's been done. It shows that the end expiratory lung pressure is 28. This is with a set P high of 38. So the driving pressure on this patient is 38 minus 28, or 10. And as with the Emoto study, a lower driving pressure seems to be a good thing. With a smaller series from shock trauma, the lower driving pressure afforded by APRV translating to at least a slightly improved mortality as compared to that seen with both volume control and pressure control, more traditional ventilation. The main point here, though, is that P low being set to 0 does not cause de-recruitment so long as T low is set appropriately. And there does seem to be a downside to setting a higher P low in regards to it compromising the releases with increased work of breathing and hypercapnia, relative hypercapnia, increased PCO2, as well as decreased mucus clearance being observed. So there is some resistance, and you don't get as effective of releases if you set a P high of 5 or 3, or certainly something higher than that. Now, I haven't yet figured out what it is with the GE 860s that we're using now, but when I try to set the P low on our current vents to 0, it kind of glitches out, and instead of saying 0, it reads off, and then just things don't work well. So anecdotally, I've kind of struggled with this. So I've taken to just setting the P low on our vents that we're currently working with to 1, and that seems to work okay. Okay, so in the vast majority of instances, you're going to set P low to 0 or to 1. depending on the type of ventilator that you're working with. Let's move on now to talk about T high. T high is, of course, the time during each cycle during which CPAP is held at the P high. So it's the time that you're holding the pressure at P high. And again, it's time control. It's utilizing time more than pressure to favorably affect ventilation and oxygenation. And the gradually increasing T high that TCAV calls for, the benefits of that have been demonstrated dating back a number of years ago. Here's a paper out of the European literature where you can see significant benefits logarithmically demonstrated here with a difference between a T high, if you will, or a time that the lungs are held at a pressure. You can see the difference between 1 second and 5 seconds, a marked difference in atelectasis here. So the benefits are shown graphically here in this article from the European literature back in the 90s, where atelectasis is shown to logarithmically decrease with airway pressures being held for 2 to 6 seconds as compared to 1 second over here. Mr. Gary Neiman, a Syracuse researcher who has done a lot of lab work on APRV with Dr. Habashi, demonstrates this with a rat lung model, which we shared in the first module, but I want to reiterate it here as a demonstration of how effective longer T highs are in at nudging, as Mr. Neiman likes to say, the lung open and keeping it there.
So what we have here is a rat lung with that has ARDS. The ARDS class part is pink, or is dark red, and the pink is the healthy tissue. We're going to hold this at inspiration for 1 second, and which is a typical conventional breath inspiratory peak. And as you can see, there's no change in the red to the pink. Here we're going to have the TCAV breath. We're going to hold it for approximately 5 seconds, which is a typical CPAP phase or T high. And you'll see at the exact same inspiratory pressure how many alveoli we're going to get recruiting. So here, as you can see, we're at 3, 4, 5, and you can continually see the red going to pink over these 5 seconds. So the exact same pressure in the CMV and the TCAV breath. The only difference is the inspiratory time is held a lot longer. So this is, and again, due to this viscoelasticity, this is what is causing the lung to progressively open or to be nudged open over time.
So again, I think as eloquently demonstrated in that model, longer T highs are effective at nudging the lung open and keeping it there in conjunction with at least initially higher P highs. Downside is that early on with the atelectatic lung, the patient has significantly increased dead space. So carbon dioxide clearance from mechanism 3 that we just looked at is significantly reduced initially. And if they've been sedated, and particularly if they're on neuromuscular blockers, then there's minimal to no spontaneous breathing happening initially, limiting mechanism 1. And so that leaves the patient, initially at least, entirely dependent upon the release phases. And a high T high means less releases. So hypercapnia, buildup of CO2, can be a big issue, leading to respiratory acidosis if you set an elevated T high initially, particularly in patients with any component of respiratory acidosis to start with. And so while you ultimately want to get to the point where T high is 90% or more of the cycle, most patients won't tolerate that initially, particularly rescue cases where you need more releases to offload carbon dioxide early on. Now, after 24 to 36 hours of stably opened alveoli, you've got more ventilation coming from mechanism 3. You become less dependent upon releases. Then that's when you can start to drop and stretch and start to, increase your T highs more effectively and more safely at that point. And the TCAV network guidelines articulate this well. and I'll just read, using a T high of 4 to 6 seconds is typical for patients with routine postoperative atelectasis or normal lungs, but is generally inadequate when using as a rescue strategy, particularly as an ARDS. When using APRV TCAV as rescue strategy, it may be necessary initially to control the patient's ventilation until mechanical and gas exchange parameters improve to avoid excessive air hunger and breathing efforts. So although we really preach don't oversedate the patients, don't neuromuscularly relax the patients, the exception to that may be particularly in a rescue type of situation when you're initially transitioning them to APRV. Sedation should be continued in consideration of neuromuscular blocking agents to control respiratory drive if necessary, just for that initial transition. In addition, the time-dependent nature of the increase in surface area for diffusive CO2 clearance may not occur for 12 to 24 hours. Therefore, when using as a rescue strategy, a briefer T-high is required to provide more bulk ventilation, more bulk CO2 blow-off until the lung has recruited and stabilized. It's important again to make the distinction between alveolar recruitment and stability. You get recruitment pretty quick with TCAV, but it's not stable. Alveolar stability is time dependent and it takes more than 24 hours to occur. And certainly you'll be checking blood gases and stuff as you transition, patients shortly after you transition, but also looking at that tidal volume, and we'll talk more about this. If your tidal volume on your releases, we're not talking about the patient's spontaneous breaths on top of CPAP, but with the releases, if your tidal volume's below 3 milliliters per kilogram, it's probably going to be necessary to go with higher P highs to get you over that hump initially. And concurrent with that, you may have to go with lower T highs and perhaps more prolonged T lows. And let's just look at a quick case study here real quick. This is a patient I took care of kind of relatively early in my TCAV experience, and frankly, in retrospect, had a number of opportunities for improvement where we could have done things better. This was a patient who had sustained multiple polytrauma, including multiple cervical fractures with epidural hematoma of the cervical spine, as well as a cardiac contusion with actually 2 episodes of cardiac arrest requiring ACLS support, a significant pelvic fracture, evidence of right lower extremity compartment syndrome, and a number of orthopedic injuries, as well as multifactorial shock. The patient was being stabilized or attempting to be stabilized in the ICU, and several days after their initial admission, 5 days specifically, they developed worsening hypoxic respiratory failure. And you can see on the morning of the day in question, the chest x-ray didn't look good, but it looked markedly worse later that night when the patient became increasingly difficult to ventilate. I was on call that night, so we saw the patient initially, and we, despite 100% FiO2 and other supportive measures, were not able to adequately oxygenate them. So we switched over to APRV, but we did so, again, just kind of using a cookbook algorithmic approach of a one-size-fits-all and not recognizing this as a rescue situation. So I've got a T high, which in retrospect is much too long here. And the patient, not surprisingly, did poorly because we weren't giving them enough releases, so they became significantly acidotic. The one thing we did do right was stayed at the bedside and watched to see how they did, and it was clear they weren't doing well from the get-go because they became increasingly tachycardic. Their tidal volumes on their releases were quite low. There was some concern that maybe there was mucus plugging going on, so we switched them to ACPC at that point. So we put them on pressure controlled ventilation, did a quick bronch, which really was unremarkable, started them on a bicarb drip, and then kind of took a little more control of the situation and sedated and neuromuscularly relaxed the patient. retried them on APRV with a more appropriate T high, cutting it down to 3, bumping the P high higher. So everything is awesome, right, with a high P high. So we bumped the P high up to 45, dropped the T high to 3, and they liked that much better. The patient responded much more favorably to that. And with ongoing APRV, along with diuresis and fluid restriction, treatment of potential diffuse bronchoalveolar pneumonia, they improved overall. Now, unfortunately, the mistakes didn't stop. You'll see that I started to try to drop and stretch a little bit too fast. Here we are before 24 hours has passed, and we're already kind of dropping the P high a little bit and trying to stretch out the T high some. But we got away with it in this instance. And the patient gradually improved over the next few days. You can see improvement here in their chest x-ray, and their overall status continued to improve, and we were able to gradually drop and stretch them out, and ultimately the patient improved. Just because of all the cervical fractures and everything going on, did ultimately require a tracheostomy, but we got them through the ARDS with APRV, which we eventually got to the right settings on. So we got there eventually, but we certainly should have done a number of things better in retrospect. And with a better knowledge now of how TCAV is actually supposed to be adaptable and how it's supposed to be used, I'm seeing much better results now. We've mentioned a few times now the Hibachi drop and stretch APRV weaning methodology. This involves gradually decreasing the P high, usually in 1 to 2 increments each time, while increasing the T high, usually by 0.5 seconds each time. And this is just kind of from a waveform standpoint, looking at the differing pressures and the different times that the pressures are utilized is how it looks. And you gradually do that, gradually dropping and stretching until the patient's somewhere around a P high of 12 to 15 with a T high of around 12 to 15. So just remember 12 to 15 centimeters of H2O and 12 to 15 seconds is when you can start really thinking about transitioning to CPAP, because again, APRV is CPAP plus releases, so APRV minus releases is CPAP. And once you're on CPAP, then you're hopefully getting close to, so long as they don't have, so long as they have a good cuff leak and so long as they have an adequate mental status, then hopefully you're close to the extubation. So here again is the basic guide, and I know I'm kind of going over and over this, but we learn by repetition. But here's the basic guide to TCAV adjustment. In regards to hypercapnia, also just want to emphasize, in addition to the changes with the parameters, remember the potential utility of lessening sedation and also of bicarbonate infusions potentially, as we did in the case study example, as I think bicarbonate infusions and permissive hypercapnia are two components of ARDS-NAT protocol, which probably still do have utility in a number of cases. And also, again, emphasize the importance of, as you're transitioning patients or making significant changes, standing at the bedside and maybe not even necessarily waiting on that blood gas, and then, look and see what their tidal volumes of the releases are. If the tidal volumes of the releases are sky high, greater than 8 milliliters per kilogram, more likely that they're less than 3 milliliters per kilogram after switching to APRV. You may not need to wait to get a gas before you increase the P high and or increase the T low, or potentially decrease the T high further. So you can make clinical decisions as well as gas guided decisions. Okay, we're in the home stretch, looking now at the final parameter, T low. T low is, however, in some ways the most important and simultaneously the most difficult of the parameters to set correctly. T-low, of course, is the duration of the release phase, which controls the amount of airway pressure and lung volume released. It facilitates the transfer of potential energy to kinetic energy generated by recoil in the thoraco-abdominal cavity. And there's more recoil with restrictive lung pathology, such as ARDS, such that these patients tend to need shorter T-lows as compared to patients with obstructive lung pathology, such as COPD, where longer T-lows are needed. And the extent of restrictive or obstructive pathology in the lung can change day by day, even hour by hour. And so it's important that the ventilator support of the patient be adaptive to where their lung compliance is at any given time. And that's where the adaptive component of time-controlled adaptive ventilation comes in. And that is primarily adapted, if you will, through the T-low phase. And it turns out that with most ARDS and other restrictive lung pathology patients, they tend to do best with a T-low, which terminates the release once the expiratory flow rate decreases to 75% of its max. Now, what's that mean? That can be visualized, or this can be visualized by looking at expiratory waveforms. So pictured here are schematic expiratory flow rate waveforms. In the first one, in A here, we have 100% of FRV is being exhaled. And so you get kind of this triangular appearance here. If, however, you terminate the expiratory gas flow at 50% of its peak, you get kind of more of a squared appearance here. If you terminate the expiratory gas flow at around 70 to 75%, you get more of this rectangular shape. And this is really what you want to see with most ARDS patients and most restrictive lung pathology patients, but we're talking primarily about utilizing APRV here with ARDS. So this is typically the expiratory flow rate pattern that you want to see. And the reason that you want to see that is because with restrictive lungs, such as with ARDS, the lung recoil is rapid. And if you don't have a short time low, the patient will be at risk for loss of that auto-PEEP and de-recruitment. And we'll show some data in a minute which supports that a sweet spot in the T-low duration is when the release is terminated after the expiratory flow rate drops below 75% of its peak. Here's what it should look like on our GE860s. Here with your pressure diagrams, you have the CPAP set up here in this instance at 22. The patient's able to spontaneously breathe on top of that, and then you get these intermittent releases where you drop down towards zero but not to zero. And your expiratory waveform has this somewhat rectangular appearance to it, being set with an expiratory flow termination to expiratory flow peak ratio of about 0.75. Here's a schematic example of this from Maria Madden, one of the senior respiratory therapists that works with the shock trauma group. And you see here with the expiratory flow rate diagram, of course, the peak expiratory flow is immediately at the beginning of the release phase, where in this example you have negative 60 liters per minute. 75% of that is 0.75 times 60, which comes out to 45, meaning that once the expiratory flow rate drops to negative 45 liters per minute, that's where you want the release phase to end, right there. You don't want it to go on all the way here because then you're going to get de-recruitment. You want it to end right here at 75% of the expiratory flow peak. That's where it should terminate. And so in this example, a T low had been somewhat arbitrarily set at 0.5 initially. Based upon this, it was adjusted down to 0.35. Now, something that's important to recognize here is that these flow spikes occur. These expiratory flow spikes, this is not the expiratory flow peak down here. This is an artifact of gas recoil. So you have to recognize this for what it is when it occurs. And the expiratory flow peak is actually right here, right at the right kind of upper aspect of this at the site of initial widening. So this is where you need to calculate, or this is really where the expiratory flow peak is at. And you need to utilize that number, not this number, because when you see this spiking, this is an artifact of gas recoil and not the true expiratory flow peak. Now, not all patients on ventilators in our ICUs obviously have restrictive lung pathology. Patients with obstructive lung pathology, such as COPD, have different needs and will typically be optimized with an EFT or a termination to peak ratio more in the range around 0.5, or in bad instances of COPD, maybe even 0.25. In this example, a patient with significant COPD was initially ventilated with a termination to peak ratio of 0.75, like we do for ARDS, had significantly low tidal volumes and developed respiratory acidosis, after which it became clear that they had a significant component of COPD, so the T low was adjusted to a termination to peak ratio of approximately 0.4 with significant improvement. So this, you can see, gives them much more time to exhale against the obstructive component. So T low needs to be tailored to the patient and to the clinical situation. In most instances of ARDS and volume overload, you're going to want to target a release termination occurring at about 75% of the expiratory flow rate. For patients with COPD, that may be significantly different and may need to be somewhere around 25% to 50%. So know the clinical situation, look at the waveforms, and know the patient's medical history to arrive at the appropriate setting of T low. And sometimes this can change as the patient situation changes, even in the same patient. This is an example from Baltimore Shock Trauma that is cited on the TCAB network. And here you have a patient with severe COPD. Initially, they were well managed with a very high T low. T low actually higher than T high in this instance due to the severe COPD, initial T low of 1.8. After, however, a sizable surgery and significant fluids essentially becoming overloaded, it was necessary ultimately to decrease the T low down to 0.8, and the T high, which was initially 1.4, is all the way up at 5 then, as well as an increase in the P high. And so at this point, really, the patients develop more restrictive issues, albeit on top of some underlying obstructive issues. So again, the importance of being adaptive. One size doesn't fit all, even for the same patient. As their lung compliance changes, the parameters which will be needed to optimally ventilate them will change, particularly in regards to T low. Okay, now where did this thought process that the termination to peak ratio 0.75 or 75, or terminating the release at 75% of the expiratory flow peak is optimal? It's pretty decent data out of shock trauma, which they've looked at in several different ways now, where that approach, as compared to multiple others, but the 75% termination to peak, or termination to peak flow at 75% was associated with the lowest amount of ventilator-induced lung injury, along with the best alveolar recruitment. And just from a pictorial standpoint here, you can see the significant difference. And here's graphically where you can see significantly diminished both microstrain and macrostrain as compared to most other options. The high PEEP option, not as much, but you see here, again, not as good at alveolar recruitment. So overall, it seems like the sweet spot for restrictive lung pathology, ARDS in particular, is terminating the release phase at an EFT to EFP of 0.75. Now, some vents, such as the Dragers, have a feature on the Dragers, it's called auto release, allowing one to automatically adjust the T-low to maintain it at a set EFT to EFP ratio. So on the Dragers, you can actually set this auto release such that the T-low will fluctuate and will change based upon the expiratory flow patterns. Those that use it, though, it sounds great, but in talking to some of them and listening to them talk, it sounds like it's still preferable to kind of eyeball it and to intermittently change the T-low yourself. In any case, it's not a feature that's available on the G860, so not something for us that we have available anyway. In practice, what I do is kind of estimate the T-low. Initially, again, set it somewhere around 0.4, typically, depending upon the scenario. And then eyeball the expiratory flow pattern. And you kind of freeze the screen, see what your expiratory flow peak is, and then calculate what 0.75 of that should be, look where that would be on the tracing, and see where your tracing is. Is your expiratory flow rate relatively square compared to that, in which case you might need to decrease the T-low? Or, are you all stretched out relative to that, in which case you might need to increase the T-low? You can also, and Dr. Farkas, who's a medical intensivist and pulmonologist at the University of Vermont, he has a critical care website called PulmCrit, which has some pretty good information on it. But one thing Dr. Farkas points out is, okay, set your T-low, kind of estimate it, and then just see what your release volumes look like. Look what your tidal volumes are reading on the release volumes. If they're significantly less than 6 milliliters per kilogram, and certainly if they're less than like 3 or 4 milliliters per kilogram, then you probably need to increase the T-low some. On the other hand, if you're banging out more than 8 milliliters per kilogram tidal volume with the T-low that you have set, then you probably need to decrease it some. And I think this is kind of it's not as quantitative, certainly, as the termination to peak ratio, but it's kind of a nice bedside common sense approach that I think serves you pretty well, and is kind of something I'm utilizing as I have time, kind of look at it a bit more quantitatively by freezing the screen and actually calculating out what the expiratory flow peak is and what the targeted EFT would be, again, 75% of the EFP. But if you're generating appropriate tidal volumes, you're probably going to be okay. So again, overview here, TCAV adjustment, dealing with oxygenation, typically P high being increase in the T high, obviously the FiO2, occasionally decreasing the T low. To deal with hypercapnia, again, P high often, particularly early on, being increased, T high potentially being decreased, lessening the sedation, using bicarb to offset, or in some instances increasing the T-low. And again, just a common sense thing is seeing what type of tidal volumes on the releases that are being generated, and maybe recognizing the need to do something even sooner along these lines. So in conclusion, why TCAV APRV? It makes sense from a conceptual standpoint, and at least in trauma patients, has pretty convincingly been shown to have improved outcomes with ARDS, and again, perhaps even more meaningfully, to significantly decrease the incidence of ARDS from occurring in the first place. Utility in other settings, I think, is evolving. Data for it is evolving, and we'll talk about that more in the next lecture. How do you do it? This is how you set it initially, but then you got to be adaptive. It's time-controlled, adaptive ventilation. You got to be adaptive, be there at the bedside initially, and adjust as appropriate. Using blood gases as needed to guide you, but also the patient's clinical picture. Thank you for your time and interest. I look forward to working with you as we move forward to try to do better and continue to improve the care of our patients in the future.